Good afternoon, everyone. So, myself, Dr. Prafulla Kumar Maharana. I'm an additional professor at RP Center, AIMS, New Delhi. So, this IC is all about endothelial dysfunction and how to tackle that for beginners. Why we have put this beginners is you all know, there are only few DMEC, DSEC surgeons here who are quite expert enough to do more than 1000 cases. So this session is not for them. This session is for beginners who are doing PKP, who want to move on to DSEC, or who are doing DSEC and who wants to start DMEC. So it will be a good one. I hope you people would like that. And I would like to invite my co-instructor, Dr. Shifali, Dr. Karan, Dr. Bhupesh. You would prefer to sit there or here? Okay. Dr. Hemlata. Okay, she is there. Dr. Aditi. तुम्हारा क्या था? ठीक है मैं छोटा सा 5 मिनट करके है ना. Okay, so and Dr. Namta Sharma, she is going to take a lecture, not a part of this IC. That's a special talk on liftographs. So I would like to start with my overview of DSEC. I'll cut it short. I'll not go into detail of that. So what is DSEC or endothelial keratoplasty? It's basically component corneal surgery. What's a component corneal surgery? Cornea has 5 layers, or if you add duas, it becomes 6 layer. So every layer can be a source of transplant to the host. That was the concept of component corneal surgery. So as you can see in this picture, simply only DMEC, only descemet membrane can be transplanted. So this is the classification of component corneal surgery. In EK, what we do, we transplant endothelium or endothelium stroma complex. So there are classically 2 techniques at present. One is DMEC, one is DSEC. Few people prefer to do PDEC also. That is also a good technique. So what is endothelial keratoplasty? Basically, these are the 3 common indications that we see in our clinical practice. So you replace the endothelium or endothelium stromal complex with the disease one. There are some rare indications also. This is a case of eye syndrome where I have done a triple procedure. You can see it's hardly difficult to find the graft. You can see the outline here in retroillumination. So the DSEK, this I have done. This is a case of ACIL with DSEC. So this is a case of CHED patient with DSEC. So there are classically 3 common indications and there are some few rare indications for endothelial keratoplasty. DMEC is not there in our course, so I'll just run through a small video. This is a technique of DMEC tissue preparation that we have published. You can go through that. In DMEC, what we do, we peel off the donor tissue, donor DMEC tissue from the donor, and we use that to replace the host endothelium complex. Okay, so this is the technique that we have discussed. But basically it is similar to all this punch and peel technique. Make a partial thickness punch, release the DM from 360 degree from the adjacent stroma. Why? Because what we realize in that paper is that the maximum adhesion between descemet layer and stroma is in the periphery. So if you release those points, then when you are peeling the DM, then the traction points are minimal. So that will lead to less chance of tear formation. So then you can peel the tissue off. As you can see here. ये आगे नहीं जाएगा क्या? So once you do that, then the next step is marking. You must have seen a lot of videos in that near live surgery. You can use a dermatological trephine, make a small 3 mm opening, then flip the donor and mark it. Often for beginners, you don't have the equipment with you, so no need to be worried about that. This is a simple Sensky hook with GV paint. I am trying to mark it. If you can purchase, you can use those P, S, F, L, all sorts of marker that is there in the market. Okay, so then you peel off the central 8 mm graft, and the case is, so this is the DMEC roll, and this is the case of herpetic endothelitis followed by decompensation, and the patient is phakic. As you can see, and in contrast to DSEC, in phakic patient DMEC is quite easy. So there are different techniques described. You can use the marker to do the descemet scoring of almost 9 mm. In DSEC, they will be telling you 8 mm is good enough, but in DMEC, remember, we need a larger area of DM scoring because you can't afford to have any small tags left. Then 2.2 incision is good enough. If you are using a injector, I prefer to use a Alcon cartridge, Mona cartridge, D cartridge, which has just 2.2 with that, the width that you need. So you can simply aspirate the tissue into that. It's very easy. You can just put a IV tube behind that cartridge and pull it off using any syringe, and then you can inject through the 2.2 entry point. So this is the DMEC tissue. Yes, just like you put intraocular lenses, you can inject into the entry chamber. Then you have to understand that aerofluid dynamics to unroll the tissue. At times you are lucky, at times you are not lucky. But if you want to really practice DMEC, then you have to do at least 50-60 wet lab procedures. Practice how to do. You have to understand when to release the fluid, when to inject fluid, when to tap, and how to tap. If you understand that, you can do DMEC. So with this I will conclude here, but remember these are the advantages of all the procedure DSEC, DMEC that we are going to demonstrate you. Early visual rehabilitation, less invasive procedure, no sutures, refractive outcomes are excellent because you are not altering the intercorneal surface. Corneal innervation is not hampered because this is just a 2.2 or 3.2 incision, and ocular surface complications are minimal because in PKP you are replacing the host surface with the donor surface. You don't know how it's going to behave. Then tectonic stability, this is probably one of the most important complications which is often ignored. If you practice in a premier institute or where the emergency services is there, we get at least 4-5 cases of graft decisions post PKP every month. So because the tectonic stability is never as good as the host cornea. In DSEC, DMEC you are not replacing the host cornea, it's just replacing a particular layer. So that stability is there and chances of rejection is also less. So with this I will conclude here, and Dr. Karan, yes, he has some lecture to take somewhere else, so we will start with his talk, DSEC in challenging cases. Then we will go back to Dr. Shefali because donor preparation is as important as doing the surgery. So then she will take a lecture about the donor preparation DSEC. Karan.
So thank you, Prafulla sir, for this wonderful opportunity. As said, I'll be talking about DSEC, the challenging cases made easy. Is my screen visible? Screen. Yeah. So let's get straight into it. So a challenging DSEC could be the result of an intraoperative complication or due to the challenging situation of the eye itself. Intraoperative complications, what you can have is a buttonhole, which can, in such a case, I had a buttonhole, and so you need to be very careful in a dissection, dissect on the other side, and then use your corneal scissors, cut it from that end, and then that's how you dissect it. Dr. Shefali will be telling about the donor preparation. So then you dissect it, and then you can use this tissue. Sometimes you have to use the crescent also in such cases, so it's a couple of modifications. In case, so you see over here what has happened is, if you look very carefully, this was a perforation that happened. So if it's in the peripheral, then you can make the incision on the other side and still use the graft. If it's central, then you might have to change your tissue. If there's any intraocular bleeding that you're encountering, in such a case, you need to use adrenaline, then use air or viscotamponade. Ideally, air is better because you don't want any HPMC, particularly in the eye when you're doing a DSEC. So you wait for it to stop, and then you can go ahead. Coming to the challenging situations of the eye. So this is a one-eyed gentleman post AGV and with advanced cupping. So this is the challenges over here are the incision entry. One thing that you need to do is you need to avoid the area of the bleb, and then as you can see, I'm making a clear corneal incision using a descemetorhexis. Then you need to enlarge this corneal incision only. Otherwise, in DSEC we prefer a sclerocorneal tunnel. The tube has to be trimmed slightly more than what I have done because this can interfere with the survival of the graft. So early detachment due to hypotony is also pretty common in such cases. So this was I use the push technique for insertion, and then always suture, at least one suture when you're doing a scleral tunnel. For corneal incisions, you have to put more sutures, put a full air bubble, and then this is how this patient did. So this patient did a very good follow-up for 4 years, and then he developed a bacterial keratitis, for which I treated it. There was also epithelial hypertrophy. Then again I repeated the DSEC. This is the POD1 picture. He's doing well right now with an uncorrected visual acuity of 624, improving to about 6.9. This is another case of post-complicated cataract surgery. So if you see over here, the epithelium is removed, for better visualization, and then you can see that there is some vitreous in the anterior chamber. So this vitreous needs to be swept off. Once that is done, you need to do a vitrectomy, because any vitreous, any iris tags, whatever are there, they can again get to the endothelium and interfere with the survival of the graft. So after doing a good vitrectomy, I realized that the IOL is unstable, so therefore I took it out. Again did some more vitrectomy. Once this vitrectomy was done, I'm happy with it. Then I checked whether there's a sulcus. If the sulcus is there, do your synechiolisis, break these synechia that are there between the capsular bag and the iris, and then you can put a 3-piece IOL into the sulcus. And then the part of which is easy is the DSEC in such situations. So the graft was inserted, a full air bubble. You can do an inferior PI, which really helps if you want to leave a full air bubble. Otherwise, 10 minutes is good enough. This is how this patient did and is doing well. This is an ultra thin lenticule. Now, this is in such situations, if it gets very thin, it can get very difficult to manage. So if you see over here, trying to insert the graft, and it got very challenging. It was folding on itself, and that time I was not a DMEC surgeon. So you have to go sometimes manipulation, so much manipulation over there. So you don't want a very thin graft also, because it gets difficult. But then, as Prafulla sir had told you, you make it shallow chamber, then tapping movements. You need to use the DMEC rules in such case. So this was about 37 microns only. This is another eye post-trab, 81-year-old with a functioning bleb. So you see over here that there was increased positive pressure that was happening. So is it a tight globe? What is happening? The iris is prolapsing. Is it suprachoroidal that is happening? It was a very confusing situation. Or is it fluid in the retrolental space? So over here, what we decided is that, we made an incision in the pars plana and did a dry vitrectomy of the pars plana. The globe became softer, and then the surgery became much easier. So you need to be, aware about these situations that are going on. This is a post-PKI. So in such situations, what really benefits is you can do a DSEC. You've done a TPK, the graft is bound to fail. So if it fails, then you can do a DSEC, and the results are really, really good in such situations. And ACIL, I don't like to put an ACIL ever. I generally explant it if it's creating the problem. But sometimes explanting is very difficult in ACIL. You need to cut the haptics. You need to be very careful to not damage the iris. This is another case with a PCIL in the anterior chamber. So this was explanted. The IOL was placed back, and then you can go ahead. This was a PCIL which was fixed abnormally with the haptics were in the anterior chamber. So decided to go ahead with this only. You can see the pictures, and this is how this patient did pretty well. A case of pseudophakic bullous keratopathy with a broken IOL. So over here, the IOL explantation was done with synechiolisis, with vitrectomy, with an SFIL, and then this is the video of the SFIL that was done over here. This is my technique that I had published, the MYX technique. So you can use any technique for SFIL. After that, after the SFIL is done, pupilloplasty in again with Dr. Amar Agarwal's technique, and then you get a good pupil, and then the DSEC graft is inserted inside. So this is how the patient was on POD1, doing well. ABK cases also, I like to implant an IOL in the same sitting if it's possible. This is another case, a 23-year-old, one-eyed, post-trab, PLPR vision was there only. Now you can see this thickening fibrotic Descemet's membrane complex. There's 360-degree anterior synechia. So I was very confused as to how to go about it. Should I do a PK? Should I do a DSEC? So the epithelium was removed. You can see once this epithelium was removed, it was the anterior chamber reconstruction that I had to go. So it was this retrocorneal membrane removal was actually the most difficult part of the surgery. I managed to do it. And once you use scissors, you use a combination of instruments over here, take it out. And once it was out, you can see how thick this membrane is. A very, very thick membrane. And once this is out, the visibility of the anterior chamber gets much better. The next step was this peripheral anterior synechiolisis, which was being done. Vitrectomy was done. You need to be careful about these iris tags, as I have mentioned, because they can again interfere with the survival of your graft. And then I did an SFIL implantation over here using the MYX technique only. So I'll skip this part. But the IOL was implanted in its position. A flange was created. So this is a sutureless technique for SFIL. And after that, the easy part is the donor insertion. But you can see that there's a interface was attached. So then you need to be careful, cut with the scissors, put this graft in, and then you can use a Boussin's glide, or you can do this needle insertion technique, whatever works. So this patient did pretty well. This is the pictures of 21 days post-op. 67 days, this is how the patient responded. You can see the flanges are stable, everything is good. The graft is only 57 microns in size, and the patient, was independent and running from being disabled earlier on. So this was the big change in him. Eye syndrome is always a challenge in such situations, so DSEC is the preferred option here. If you case like CHED, a non-DSEC where you don't strip the Descemet's membrane can be done, and this is how this patient did pretty well. So that I would conclude by saying that the difficult part isn't the DSEC, but the anterior chamber construction, reconstruction and management. So special thanks to my AK teachers. Thank you so much.
Thank you, Karan, for being on time. So before I think let's go with Dr. Shefali's talk. She will be talking about the basic steps, and then we'll take up questions about this. You want to leave?
Right.
So Dr. Karan has some other commitments, so he will leave us for now. But please join us back for a photograph.
Full screen.
And all the queries will answer, don't worry. Yeah, Dr. Shefali.
Thank you, Dr. Prafulla, and good morning, everyone.
But before she starts, this is a very important talk by Dr. Shefali. If you know DSEC donor preparation, then you are not dependent on anybody. Okay, so you can do the entire procedure on your own. So please listen to this talk carefully.
My own preparations are also, all of them are manual.
Yes.
Good morning, everyone. So I'll be speaking on manual preparation of DSEC lenticule and the surgical technique of manual DSEC. So first of all, I would like to draw your attention to this recently published article in IJO, where Pamaji et al. Highlighted the trends in the indication of keratoplasty in last 2 decades in North and Central India. And if we see this table, post-cataract surgery edema is one of the most important reasons for which keratoplasty was done in last 2 decades here. And as Dr. Prafulla already mentioned, that endothelial keratoplasty is the procedure of choice for these cases. But still, if we are doing full thickness keratoplasty for them, just because of the reason that we don't have access to automated keratome, or our patient cannot afford pre-cut lenticule, then it's not good, because manual preparation of donor lenticule is really doable and it gives equally good results. So if you are working in resource limited setting, like I'm working in medical college, and all the medical colleges and government institutions, we have eye banks with us, so we have access to cornea, but neither we have automated keratome nor we have a specular microscope. So the question is, without knowing endothelial cell counts, can we use any tissue for DSEC? The answer is yes, we can. I'm going to share with you how we have started our DSEC journey in the medical college just 3 years ago. So after reading few articles of Dr. Samar Basak sir, we made a protocol in the department. And whenever the retrieved cornea fulfills these criteria which are listed over here, then only we use that tissue for DSEC. So we kept the maximum age of donor 65, maximum retrieval time within 6 hours of death. We always use phakic eyes. Definitely corneasol preserved tissue we use, and at least good grade corneal tissue on slit lamp examination. So now let's come to this, how many instruments and what we need for the preparation of DSEC lenticule manually. So we need artificial chamber. I use titanium one. We need 2 lamellar dissector, straight and curved one, Sinski and disposable refine for marking, 350 microns guarded knife for initial incision, crescent knife for initial dissection, marker 5 ml syringe. We need graft holder, Macpherson, Teflon block and good quality cornea. Now let's come to the manual preparation of DSEC lenticule. So after mounting your cornea on the donor cornea on the artificial chamber, first we mark the center with Sinski and disposable refine. Then at limbus, we will give 3 mm incision with 350 microns guarded knife. And initial dissection, we always start with crescent knife. And once we get the plane deep enough, then we take straight lamellar dissector first and go up to the center. And then I always dissect on one side first, complete it, and then I'll come back to the center and then on the other side. And we will have to dissect all the way away from the this refine mark. because at the time of final cut, we don't want any adhesions, as Dr. Karan had shown you in one case. Now we take the curved lamellar dissector and we go to the opposite limbus straight away. Then we will repeat the procedure, complete on one side and then on the other side. And it hardly takes 7 to 8 minutes in preparing this lenticule. Now let's come to the surgical technique. So if you are a beginner, you have not done DSEK surgery. So as we all know, there are so many causes of endothelial dysfunction. So always start with a straightforward case of pseudophakic bullous keratopathy. And straightforward means your IOL should be in posterior chamber. There should be deep AC because we will do lots of manipulation in the AC. Minimal or no peripheral anterior synechiae is the preferred one, and no central corneal scarring, stromal scarring for the good results and to increase your confidence. Now, keep minimum 3 months window period between the cataract surgery and the planned DSEK. You can keep it more, but at least 3 months. And definitely there should be some potential for visual recovery. So now preoperative workup is same as we do in all cases of cornea. But here AIOCT is very important for us because we do AIOCT preoperatively to measure the thickness of cornea. Like in this case, you can see 957 is the preoperative corneal thickness. But if you can appreciate, there's no stromal scarring. So these are the good cases to start with. And then we do AIOCT on day 1 to see the attachment of the lenticule. Here you can see the attachment, perfect attachment. You can see the orientation by seeing this acute angle. And more importantly, because we don't have automated keratome, so we cannot measure the thickness of lenticule intraoperatively. So we will do it on day 1 and we will keep it as a baseline. Then at different time intervals during follow-up, we keep on doing AIOCT and we can compare our results. And you can see after 1 year follow-up, the overall corneal thickness is only 618 microns, out of which lenticular thickness is 111 micron. And preoperatively, you just see here, it was 957. So it is really encouraging. Now let's come to the surgical technique. So we'll start with descemetorrhexis. So after debriding the loose epithelium, we will mark the center. Actually, this is reference marking, which will guide us during descemetorrhexis as well as at the time of DSEK lenticule centration. In this patient, I was sitting temporarily, so I made a side port at 6 o'clock. And then I stained the descemetes with trypan blue. I usually prefer to do descemetorrhexis under viscoelastic. So because chamber doesn't collapse so much. Then with reverse Hinsky, we will keep on scoring from all around in a circle. And if you feel like that chamber is collapsing, you can refill the chamber with viscoelastic again. And once you are sure that you have scored the descemetes from all around, then you fold it and try to bring it towards the side port. And at the end, we should always examine the descemetes under microscope to confirm that we have taken it out completely or the tags are left behind. That is very, and then you wash the chamber thoroughly to remove all the viscoelastic. I use push-in technique with 2060 needle. Here I am using 2 limbs forceps, one for holding the cap and one for holding the lenticule. I put 1 drop of cohesive viscoelastic in front of the clear corneal incision, and I kept the lenticule endothelial surface down in front of the incision. And then with 2060 bevel up needle, I take it inside the AC. And if you can notice, it is not opened completely. So I'm using BSS. I go over the stromal surface and just inject little fluid and it is open now. If like this, in this case, it is very well centered. So I just inject more air. We need high pressure in the eye at least for 1 hour. And end point is just see the double ring sign. This is another case, but this was a case of aphakic bullous keratopathy. Again, I'm using the 2 limbs forceps. And just place it near the clear corneal incision. And with 2060 bevel up needle, gently you just take it inside. And that's it. And either from the main port or from the side port, just put a small air bubble if it is not centered. So after stroking, it will come in the center. Then inject more air. And end point is again the double ring sign and high IOP. So double ring sign actually is the confirmation of the correct orientation of your lenticule intraoperatively. Post-op and follow-up regime is same as we do in all cases of full thickness keratoplasty, but less aggressive with obvious reasons. So now let's come to the results. So first we will show you the immediate post-op results. This was the case whose video I have shown you. So in this slide we have shown the day 2 post-op and 1 month post-op after manual DSEC. And these patients have completed 1 year follow-up with us after manual DSEC. They have completed 2 years of follow-up. They have completed more than 2.5, in fact, near about 3 years follow-up with us. And we have done manual DSEC for long-standing bullous keratopathy cases also, where the visual recovery is not that great because of this stromal scarring. But symptomatically, these patients also, they do very well. And they are very happy patients because all photophobia, watering, pain, all is gone. Complications are part and parcel of any surgery, so we encountered a few like graft detachment in this case, but this graft, you can see the central graft detachment and it was reattached with rebubbling. Pupillary block glaucoma is common when we are a beginner because in apprehension of graft detachment, we overfill the chamber. So the tip is at the end of surgery, just put 1 drop of atropine. And 1 hour is more than enough for a graft to get attached. So bring your patient back in OR and do air fluid exchange. And just leave a slightly smaller air bubble than your lenticule. Then you won't encounter with this complication. Post-DSEC infection is not that common. But when the patient is suffering from other systemic illnesses like uncontrolled diabetes, this patient was on dialysis, not very compliant with follow-ups and medication. So she developed. And in this case, I made a scleral tunnel for graft insertion. And I found that that was not self-sealing. So make sure your tunnels should be self-sealing whenever you make scleral tunnel. Our initial work of manual DSEC we have published in Indian Journal of Clinical and Experimental Ophthalmology. So if you want to start your manual DSEC journey, it could be of help. So please go through it. And in the last, I would like to conclude by saying it's a very safe, feasible, and low-cost surgical procedure with good visual outcome. Thank you. Thank you for patient listening.
Thank you, Dr. Sefali. Since these were the 2 talks on DSEK, so any questions from the audience about manual DSEC? Any points from the panelist? Okay, Dr. Sefali, one question. You use viscoelastic for decimal scoring. So could you specify which viscoelastic you would prefer and which you should avoid?
Actually, cohesive is better. So we can take it out.
It's always cohesive, like
yes.
Hilon, because that comes as a bolus.
Easily.
If you use something like HPMC, then that will stick to the endothelium or the stroma, posterior stroma, and there is a risk of graft detachment of fluid in the post-op period. So that is one part. And how do you assess? Because most of the time for beginners, when they start the dissection plane, how do you decide what exactly is your dissection plane?
Actually, I put a small air bubble in the and when you start dissecting, if you are in the deeper plane, it goes very easily. When you are in the deeper plane, because the arrangement of corneal stroma fibers are not that cross-linked or very tough.
So endpoint is start with little bit resistance. Then once you feel that okay, my dissection is going easy, don't go further deeper. I think
yes,
that is what is for manual DSEC.
Once you get a plane, then you'll have to be in that plane only. Otherwise, it will not be very smooth, and it will not. 350 for initially as a beginner they can start with, and when you become confident, you can use 450 microns guarded knife. 450 is okay. Preoperative OCT? Yes.
So that we can decide at what depth we should go, how thick is the cornea and all those things.
Depending on the pre-op OCT, we decide the thickness of lenticule.
Guarded knife.
Guarded
which
knife.
one to use?
No, not at all. Because you will have to debride the epithelium also. Then you don't know what would be the rest of the corneal thickness intraoperatively. Standard in the beginning, just 3 years ago, I started what I saw at day 1 post-op. It was 250 microns, my lenticular thickness, which came to 100 microns within a year. But now I can go ahead with 150 microns.
That is what we discussed. You have to practice. If you want to do EK, practice in wet lab. Thank you, Dr. Sharma.
Thank you.
Thank you.
Yes, please. Meanwhile, Dr. Bhupesh, you please get ready your PPT.
Yes, you can. See, you can give results in PK. Okay, when you are confident, you can use that tissue for PK. That was the thing which came into my mind. If I can give result with this tissue in PK, I can also use this tissue for DSEC. Let me try, and that's why we started very slow. In last 3 years, we have done only 40 cases. So, and you see, we waited for the results. Initially, we were very slow. In 1 month, I did only 1 case. And then I was confident, yes, my cornea is good. And if you use slit lamp examination, you use phakic eyes where no intervention was done in the life, then definitely you can expect the good endothelial cell count, and age is again a thing. So these are the few things, and definitely corneasol preserved tissue.
So there are, as the Dr. Sefali highlighted, based on history, like patient factor, and also clinically you can see the compactness of stroma and age of the donor. If the donor is below 40, most likely the endothelial count will be good, right? And the stroma is contact, again the endothelial count will be good. And third is you can also check for death preservation and death enucleation time. If the tissue is enucleated within 6 hours, then most likely the tissue will be good quality. Anything above that, little bit worried about the, and also type of cause of death. Sudden cardiac arrest, tissue will be good, but hanging, road traffic accident, the most likely some sort of trauma to the cornea may be there.
Like I'm working in the medical college, so hospital corneal retrieval is not that good in our college. So usually we get voluntary donation. So most of the time the age of the donor is above 70. So we don't use it. We always restrict to 60, 65 plus only cornea. That's the maximum age limit for using that tissue for DSEC preparation.
So okay, now we move on to the next surgical step, that is DSAEK. A stands for automated. Bhupesh, do you have any video of donor preparation?
No, just insertion devices.
Okay, so Dr. Bhupesh is going to cover the insertion part and preparation part. Dr. Hemlata, do you have any video? Okay, in the end, I'll run one video how to prepare using a microkeratome. But now for this talk, Dr. Bhupesh will cover how to insert. Preparation is similar to what Dr. Shefali showed you. Host preparation is same in both DSEC and DMEC. Only difference is preparation and insertion. Bhupesh.
So, good afternoon, and thank you, Dr. Prafulla and Dr. Shefali, for including me in this interesting instruction course. And I must say, Dr. Shefali is a very good and competent surgeon.
Prolific and brave surgeon.
Brave surgeon, and she can do everything manually. So, but I don't prefer manually, although I've learned in fellowship, but shifted totally to automated. And I think if we are charging good, so we should give the best. Okay, so no financial disclosures in any of the techniques mentioned here. So this is just an introduction slide. It's already covered, and we should be thankful to Jared Mellis for discovering this technique and teaching the whole world how to do DSEC surgery. The technique is simple, just mark the cornea and do the stripping. Stripping is very simple, just avoid the central visual axis area and first score around the marked area and then try to take out the desmids in toto and just examine it, and job is done. So DSEC or DSEC, already Praful covered that this A stand for automated and DSEC is a manual DSEC. So this surgery has 3 steps. First is donor preparation, second is recipient preparation, and third is donor lenticular insertion. Recipient preparation is just a DM score. The scoring, donor preparation, we'll show it later. And the last part is donor lenticular insertion. If you have a good graft, good patient, but if you don't insert it properly, you won't get the good results. So insertion is as important as the donor as well as the recipient. So donor lenticular insertion, there are numerous techniques. More than 10, 15 techniques, devices are there in the market, and people are using them, getting good results. Although what matters is what works well in your hand. And broadly, they are categorized into 2 categories, push-in techniques and pull-through techniques. Push-in literally means pushing the graft inside the eye, and pulling literally means pulling from the opposite end of the cornea. So pull-through techniques, in pull-through techniques, the donor is docked into the main incision and pulled within the eye from the opposite small clear corneal incision or scleral incision with the help of forceps or sutures or any other way. One of the most commonly performed full thickness techniques is the use of Bucin glide that I am also using currently, and the glide with the donor tissue is docked into the scleral tunnel incision or clear corneal incision, and the donor lenticule is pulled into the anterior chamber by grasping the edge of the donor lenticule with the bent disposable needle or with some forceps from the opposite port. Pushing techniques, the donor is pushed in through the main incision with forceps, glides, injectors. The common instruments that are used for pushing techniques are tackofold and sheets glide, endoserters, endoinjectors. In general, these glides allow better maintenance of anterior chamber during the procedure, better unfolding and being bimanual, so it's very easy to learn and perform. So these are the common techniques that I have practiced: taco, sheets glide, tan endo glide, Busing glide, endoserter, although not much experience with the endoserter. So I started my fellowship at LVPI and I learned sheets glide there. So sheet glide was the preferred method in 2010 at LVPI. So sheet glide is a very simple glide that we use for IOLs also. It's similar to that. You can use similar glide for the DSEC also. Just you have to give the incision of 4.5 to 5 millimeter, place the graft and push it inside. This is the surgery that's done. Very easy, almost cheap, or almost good for SN Medical College or any other medical college where finances is the issue. This sheets glide is a very good technique for the beginners also. And studies have shown that the cell loss is around 25% with sheets glide. Although once you start doing a lot of cases, this goes down significantly. So this is a case of sheets glide. Make the corneal incision. I preferred corneal incisions in all these surgeries, and you have to inject some, place some viscoelastic at the end of the tunnel. This beginning of the tunnel, and this is the graft. All my cases are automated, so just you have to remove the cap, and you get a lenticule of around 80 to 100 micron. And most of the institutes are giving pre-cut donor tissues. So if you can afford, always go for pre-cut. And then with the help of Sinsky, just push the tissue inside. So you have seen that there is no folding of the graft. Manipulation is very minimal, just 5-7 seconds, and then simply give some saline inside so that the AC will be inflated. Don't push too much saline, otherwise graft will come out. So we have to be very gentle and careful. Take out the glide and give small air injection so that the graft don't fall on the iris. Don't inject completely, otherwise when you suture, the air will come out. So it will destabilize the graft. So put the suture, 3 sutures are good enough for these cases, and then inject air. And surgery is done. Then after LVPI, I went to Narayana for another fellowship in refractive and cornea, and there I learned tackofold technique. Although tackofold technique is the primitive technique for DSEC tissue insertion, but I have seen good results with this technique also there, in which you have to use single point fixation forceps. So you see this forceps, only at this point you are holding the graft. These points are not pressing too much, although gently, and you can fold in 50-50 or 60-40. 60-40 works well because unfolding becomes easier with this configuration. And the same technique you have to push in and then again unfold and put the air. And then I went to SNEC to Dr. George Mehta to see what he's doing. And there I saw the tan endo glide technique. Also, it's a very fancy technique, but it's costly and doesn't suit Indian economy. So although I've learned this technique, you have to place the graft here in this cartridge, put some viscoelastic here. And this is an automated system. And once it is docked, so the graft curl inside out. So you can see the double curl folding inside. And then you have to reverse the orientation and inject in the anterior chamber. The sad part is this is a one-time use device, so it becomes very costly. And when you inject in the anterior chamber, so it will automatically unfold on the stroma, and then the rest of the steps are same. And then I did a short fellowship at UCLA, and there the preferred technique was Busing glide. So Busing glide, although it's challenging to learn for me because sheets and taco folds are very easy and easy to learn technique. And Busin, I used to face a lot of challenge while pulling the graft. AC becomes shallow, iris used to come from the different side ports. So you have to put the graft here and then pull it from the opposite end like this. So this is the surgery of Busin glide. So coming back from UCL, I started doing Busin glide, and I face the challenges every time. That when I push the graft, AC becomes shallow, iris pigment release, and all those things were happening with me. So it is done with the AC maintainer, and then inject the air. And 40 minutes to 1 hour is sufficient for graft attachment. And I always prefer to do anti-segment OCT just after the surgery to confirm that graft is attached or not, because next day taking the patient back to OR is more challenging in private practice. So, sorry. So I did a small modification that I want to see in Busin, show you in Busin glide. So Busin glide is a standard straight handle device, and your both hands are at 180 degree apart when you are pulling the graft. So because of this arms away from your body line, your hands become unstable and you become tired very soon. So just to take care of this issue, I'll show you. So I've been using for many years, but every time I felt that there should be a way to make it more comfortable for myself. Looking at the design of Busin glide, it is a straight handle device with a groove on the other side for holding the donor lenticule. While using this device, Busin glide and DSEC forceps are 180 degree apart, and both the hands of the surgeon are opposite to each other. Due to this, both the arms move away from the body line while operating. This causes instability of the wrist and fine movements become coarse. This happens because the elbow joint is unsupported during this step. Modify this design and make it more ergonomically suited. I modified the design of Busin glide and gave a 90 degree angulation from the handle. Separate glide for the right and left eye was attached to the handle on the opposite sides. The internal diameter of the glide was 4.2 mm and the external diameter was 4.8 mm. The plate for placing the tissue was curved to hold the donor tissue in a natural curvature of the cornea. While using this modified device, although the tip of the glide is at 180 degree apart from the DSEC forceps, but the handle of the device is 90 degree from the forceps. Due to this change in the design of the glide, the arm stays closer to the body line and making it more stable during the procedure. The surgeon sits temporally, and after placing the DSEC graft on this modified Busin glide, the donor lenticule is pulled into the glide. From external view, the position of instruments can be visualized. At this point, arm stays closer to the body, providing better stability and fine control on the surgical steps. So this is a small modification that I did in this device, and I'm very happy with this modification. And then I reviewed the literature and found that different studies have shown different results, although these studies are almost 15 years or 10 years older. And if someone is publishing something, he should be good at that. So like if I used to do sheets glide 10 years before, and my result now is much better with the sheets glide also. So results keep on changing. So you should not take anybody's that he has shown that 25% is a cell loss or 30% is a cell loss. Doctors are giving good result with all the devices. And then endoglide with the Busin glide, they have shown the Busin glide is a 47% cell loss, which is impossible to think right now. And the third is the Busin glide with forceps, and they have showed that the forceps is showing very high endothelial cell loss, and Busin glide is better. So different studies, different outcome. You have to judge what works well in your hand. So in conclusion, successful DSEC surgery can be done with numerous techniques. Minor donor tissue manipulation should be the target. Sheets glide has the least learning curve and easy for beginners. Taco fold technique showed maximum endothelial cell loss as well as lenticular attachment in my study that I did at our center. And 10 endoglide is a better technique in terms of endothelial cell loss. Different techniques works well with different surgeons, and there is no gold standard technique for DSEC tissue insertion. Thank you so much.
Thank you, Bhupesh. Next, Dr. Hemlata is going to deal with the second difficult situation. Then we'll take the questions for both the talks together.
Beautiful surgery, sir. Sir, I have one question. Right now, which glide you are using right now?
I'm using my modified using glide.
Okay. Thank you. Yeah, good morning, everyone. So today I'll be presenting on DSEC in different situations. I would like to thank Prafull for giving me this opportunity. So normally around 60 to 70% of patients we see are normal corneal decompensation with a well-centered IOL and or a normal phakic lens. But we do come across some situations where we have to alter our technique, like I'll be discussing now. So we come across patients where we have to do DSEC in vitrectomized eyes, or after a failed penetrating keratoplasty, or when we have to combine it with cataract surgery, or in patients with a prior glaucoma surgery, or in patients with complex anterior segment changes. So if you see these complex anterior segment changes, these can be anterior synecdoche of the iris, large iris defects, and patients who have iridocorneal endothelial syndrome. Especially in these patients, we have to reconstruct the iris and iris lens diaphragm either intraoperatively or preoperatively. Otherwise, the air can escape into the posterior chamber and can lead to graft dislocation in the immediate postoperative period. In patients with FAK or subluxated posterior chamber IOL, similar situations where the air can escape into the posterior chamber and can lead to graft dislocation. And in patients with anterior chamber IOL or phakic IOL, because of close proximity of the lens to the tissue, there are chances that more failure of the graft. So especially in these patients, we have to size the graft also, especially in patients with anterior synecdoche, because the expansion of the air bubble will be altered. So this is a case of aphakic bullous keratopathy. You can see the fibrosed epithelium with areas of degeneration and superficial vascularization. In B-scan, we have seen that in this patient, there is a dislocated IOL. So first, initially, we planned DSEC in this patient. And when I removed the epithelium, you can see small area of degeneration and which was scraped. So the rest of the steps are almost similar, stripping of the epithelium, especially in these patients because the air tends to escape into the posterior chamber. So we have to replace that air with fluid, and then followed by when we place the air bubble, the chamber will be stable like in this patient. So you can see on day 1 the well attached graft, and at 7 days the cornea has cleared reasonably well, and you can see the iris details, and 1 month later we planned SFL for this patient. So this is another case where there was a failed DSEC. This patient I have operated 1 year back with anterior chamber IOL, but after 1 year he came back with a failed graft. So this time we took the patient to do a scleral fixated IOL along with DSEC. So this patient conjunctival peritomy was done with partial thickness scleral pockets, a 5.5 mm scleral tunnel made, and then epithelium scraped. So this patient, the anterior chamber IOL was very tightly stuck, so we had to go underneath the IOL and then cut both the optic and haptic junction, and then remove the optic and haptic separately. So pars plana vitrectomy was done, and then a 3-piece IOL was placed, and then it was fixed into the scleral pockets. So the donor tissue that was prepared was inserted after removing this failed DSEC graft. The conjunctiva was closed. So this patient did very well on day 1 post-op, and at this 10 days and at 3 months, he has 20/60 vision. So this is another case where post PKB failed graft. So this is the second graft which is failed. So this time I prefer to do a DSEC in this patient. If your astigmatism is reasonably good, there is no need for suture removal. You can do DSEC in the same patient. So the conjunctival peritomy done and very small tunnel was made. Especially in these patients, care should be taken that you should not touch the graft host junction. So even while doing the tunnel, very small tunnel was made, and then staining. And especially in these patients, they have iris synechiae at the graft host junction. So these should be released so that your air expands well and your tissue also attached well. So this scoring of the desma should also be done inside to the graft host junction. And viscoelastic should also be very well washed so that it does not interfere with the attachment of the graft. So this patient on day one, so very well attached DSEC graft. This is another case of post-viral keratitis, corneal decompensation with healed neurotrophic ulcer and cataract. So I plan to do both the cataract and the DSEC at the same sitting. So you can see healed neurotrophic ulcer. This patient is almost on antivirals for at least 1 year and he had no recurrent episodes after that. So almost the steps are similar because this patient had a very hazy cornea, so I prefer to do small incision cataract surgery. So at least the staining should be done 2 or 3 times so that your view for the capsule and the rest of the steps for the cataract becomes better. So immediately after the cataract is extracted, you can see the pupil has become very small. So at this, it is like you have to struggle a lot to do the rest of the steps like a cortical wash and placing the IOL. So they should be done very slowly and deliberately to get better results. So even because of the scarring, you can see the DM is also stripped in pieces. So I have scrape the neurotrophic edge of the neurotrophic ulcer also so that the amount of astigmatism also decreases in the post-operative period. And I routinely do the sheath glide technique. So this patient on day 1 surgery and at 1 week can see the density of the scar has also reduced and this patient is doing very well. So this is another case of post-viral keratitis, corneal decompensation with cataract. Because in this patient the view is better, I plan to do a phacoemulsification with an ultra-thin lenticule. You can see the center only, the edema is confined to the center only. So routine phacoemulsification steps were done, and to make the view better you can scrape the epithelium. So the single piece IOL was inserted into the bag, and because of the small incision size, I plan to use ultra thin lenticule. So the DM was scored. Immediately after doing cataract, thorough visco wash should be done, otherwise it can interfere with the attachment of your lenticule. So it is very easy to insert this ultra thin lenticule through the small incision. And you can see on day 1 surgery and at 1 month, and this patient has improved to 6/12 vision and doing very well. And he is on prophylaxis for ACV for another 1 year. So this is the ultra thin lenticule, almost less than 30 microns. So I want to thank Prafulla. Though DSEC gives better results compared to the optical keratoplasty, definitely it is a very viable option for visual rehabilitation, especially in these patients. Thank you very much.
Thank you. Thank you, Amrita. I was about to ask you to stop because they will take forward the concept that DSEC is done in all such difficult cases. Normally we do it in routine cases, PBK, posterior or FECD cases. And before Aditi could start, I'll just put few questions to the audience or maybe the panelist, because these were the point, that were the difficulty that few of our speakers they encounter. First is thin graft, which Karan showed you, right? Any specific trick for thin graft? No, if you have a thin graft
Insertion.
and the graft is getting folded onto itself, which the current showed. So how to tackle such cases? Yes. So one thing you can do is you can stain the graft. Okay, that is one thing you can do. Second, once your graft is dissected, you can keep it in BSS for some time. That way the tissue becomes hydrated, and then that becomes little bit easier for you to handle. And if nothing works, you don't have a choice. You have to go in with a reverse Sinski hook and make a rotating movement and pull it to the center. The second was,
Put the graft in BSS or saline, you should mark the graft.
this is what I do. First you have to stain or mark a put SP any mark, then you put it in the BSL.
Normally we don't mark DSEC.
The second was ACL with DSEC, which Karan said I don't prefer. What's your take on that? ACL with DSEC.
I think we can do ACL with DSEC. There is a published study from LUPI group,
Yeah, true.
and they have shown very good results. So, but ACL should be placed nicely. That is
So
important.
it has to be stable. And the Ang et al. Study, which from SNEC, they suggest the gap should be at least 1.5. Should have at least 1.5 mm of working space with ACL in situ. Then only you should go for a DSEC.
No, it's not like
it
that.
has to be stable. See, the ACL has to be stable.
Yeah, if ACL is stable and endothelium is deep enough, you can go for there is no progressive cell loss because of ACL. That's a normal cell loss. What will happen?
So, okay, we'll move on to the
I'll
next
start
talk
fast.
by Dr. Aditi. Aditi, you have very limited time. We have to give 10 minutes to Dr. Namta
Can we
Sharma.
have it on the screen, please?
Ma'am, please come.
So after seeing all these beautiful surgeries of DSEC in complicated cases, the most important thing that we gather today, a good donor tissue. But that is the limiting factor. We all do not get good corneal tissues. The availability is less. The burden is so much. So what are the alternative methods? Can we do something? Can we do something to reduce the burden of this corneal donor, or to postpone or prevent the need of corneal transplant? Are there any alternative to EK? So to come with the answers, there are medication, ROCK inhibitor. These are all alternative. I'll make it very clear. They are not they are just alternative methods to delay. So medications like ROCK inhibitors, DSO direct, I'll show you a video about it, tissue engineering, cultured human corneal endothelial cell injection, and the end game, that is artificial endothelial layer. So Fuchs, we have already discussed a lot. So the main important problem is this production of excessive abnormal ECM, which thickens the DM, and this leads to the apoptosis. So then we were introduced to ROCK inhibitors, which was being used in glaucoma patients as well. So we get netrasodil and rapasodil. So now the first one has an additional effect because it decreases the IOP as well by reducing the production of aqueous humor. So in combined cases which have a corneal and glaucoma issue, we can use it, and what is more commonly used by all of us is rapasodil. So now coming to what is the side effects. So there are not very gross side effects of it, but yes, there are some limiting factors like rapasodil. The ones in the red are of rapasodil, the conjunctival hyperemia, blepharitis, fronitazodil, reticular honeycomb. We have seen beautiful publications in IJO. So this decreases once we stop this drop, and cornea verticillata. So now there have been multiple studies regarding the use of these ROCK inhibitors, and what we have understood is that they activate the corneal endothelial cell migration. The healthy ones from the periphery migrate towards the center and activate cell proliferation. So now these are the photographs. You can see the hyperemia, which goes away after 15 minutes of that, but the patient is very symptomatic during that time. And this reticular honeycomb pattern, which is very commonly seen, or a cornea verticillata, which can be seen after nitazoxanide. So now ROCK inhibitors, apart from using them on their own, they can be combined with certain surgical procedures like DVEC or DSO. So now what is it? So here's a small video. So here we remove the central 4 millimeter of the desmet. So it's like a desmetorexis. We are removing it. And after that, we can start with a ROCK inhibitors. So now again, the aim is to delay this central corneal edema before we are referring to a patient, or the patient is waiting for a EK. So DSO, there is no need of a donor tissue, but it requires a careful patient selection. It is a simple technical procedure, but yes, we have to see the long-term results. So DVEC or DSO, it is not a total alternative, but we can do it to delay and prevent an exact need of EK, very urgent need of EK. Now DVEC, this relies on a healthy peripheral corneal endothelial cells, which are going to migrate toward the center and repopulate, right? And if we complement it with a ROCK inhibitor, that can help by regulation of the cell migration, proliferation, and decreasing of this apoptosis. So now we can look at this study where we compared a case of using ROCK inhibitor after doing a DSO plus as compared to that without a DSO. So it was seen that if we can complement it with surgical technique, the results are better. There have been multiple studies regarding it, but due to shortage of time, I'll skip it. What else? The Kinoshita group and all have done the cultured human corneal endothelial cells supplemented with ROCK inhibitors, leading to clearing of cornea. This is a very beautiful, table which has all the current studies which have been done using ROCK inhibitors, DSEC, DVEC, and so to conclude, human tissue is precious, and today we have all learned how to use them beautifully and optimal handling of corneal tissue. So we have to take the best combination of the alternative methods till the game changer comes. Thank you so much. I hope I have done before time.
Yeah, very good.
Thank you, Aditi.
Thank you so much.
So I think Bhupesh, you missed fellowship for this.
Yes. Yes. I have to go to Japan, I think.
Yes.
To Kinoshita.
Okay, so with this, I think the endothelial dysfunction part, we are over with that session. Next is Professor Namta Sharma. You all know ma'am. Ma'am is going to speak on a different aspect, or that is dry eye, immunomodulator therapy in dry eye, Lifetigrast. So it's a new product, and ma'am is doing some research on that, and she's going to present that one.
This is basically a sponsor's call, so this has to be fulfilled.
I was avoiding to say that.
No, it is perfectly all right. There is no this thing in it at all. So I will be, of course, I've been involved in the multicentric trial with for this product, Lifetigrast, which is 5%, which is very soon coming to the Indian market. And dry eye disease, I think we all know, is much more prevalent than what we used to think. Close to 50% of the patients have dry eye, and there is an ocular surface immune response also for this. Lifetigrast has got high aqueous solubility, is well tolerated, has short half-life with high clearance rate and low systemic exposure, is isotonic with human tears. It has a unique mechanism of action, and rapid absorption into the ocular tissues is also there apart from this, and it also gets rapidly eliminated from the system. So it alleviates both the signs and the symptoms of dry eye disease, which allows good therapeutic efficacy as ophthalmic drops, and protects the corneal surfaces, and is also well tolerated locally as well as systemically. So basically what it does is that it binds the Lifetigrast 1 binds on the leukocytes and blocks their binding to ICAM1 in the adhesion, extravasation, migration, activation, cytokine secretion, and proliferation of these leukocytes in the inflammatory cells. And formation of this synapse of Lifetigrast with ICAM1 binding facilitates the T cell proliferation, cytokine release, and recruitment of more T cells at the inflammatory sites. And that is what Lifetigrast is trying to act on. It targets the LFA-ICAM complex, and it suppresses the inflammation by mimicking ICAM1, and by blocking the interaction between Lifetigrast and ICAM1, it is able, LFA1 and ICAM1, it is able to disrupt the various key steps which are there in T cell mediated inflammation, which is responsible for the dryness. So basically, inhibition of T cell activation, cytokine release, formation of immunological synapse, and decrease of ocular inflammatory cycle does occur. And it is being used extensively in the other countries in our continent, but not in India, but will be available in India shortly. These are just in vitro assays which have proved that it inhibits the release of cytokines, interferon, etc. And again, this is to show the same pictographically, and there are various studies which have shown that it does normalize the various parameters, and these are the published studies on literature which have shown that there would be less amount of staining which will be there, the ocular surface disease index would improve, and the symptoms would improve, and the eye dryness score also would improve. OPUS trials have been done, and these are randomized double-blind placebo-controlled phase 3 studies where topical lifitegrast 5% or placebo BD was used, and there were 3 periods, that is screening, treatment and follow-up, and the eligible participants they were included were more than 18 years and who had who actually had dry eye. In combination with the earlier studies and trials, OPUS trials, clinical trials have clearly shown that lifitegrast does decrease corneal epitheliopathy and holds promise as a novel integrant antagonist for treatment of both signs and symptoms of dry eye disease and warrants additional investigation. So this was the randomized control trial, which is multicentric, done across all centers, 4 centers across India, and these were the primary efficacy endpoint: the eye dryness score, ocular discomfort score, OSDI, and tear film breakup time. And the secondary efficacy endpoints were Schirmer tear test, corneal fluorescein staining score, and subject rated global improvement score. And total of 370 patients were enrolled and were randomized, and this was conducted across 10 centers across India. So the results have been quite good in terms of age, height, weight, gender, etc. There was no difference, but if you look at the eye dryness score, there is a trend of decrease in the eye dryness score in the group where lifitegrast was given, and this change was statistically significant in those cases where this was given as opposed to those where it was not given, and same thing for ocular discomfort score as well, and likewise for the ocular surface disease index score as well as the tear film breakup time. Now, even the Schirmer tear test, the fluorescein staining score and the conjunctival redness score showed that all the parameters were significantly improved with the use of the lifitegrast, and the percentage of changes were higher as far as for all of these when you box plot for lifitegrast group as compared to the CMC group, which was group P. As far as the adverse events were there, they were reported in both the groups. 3% reported in the lifitegrast group and 5% in the CMC group. All of them were mild to moderate, and they resolved without any sequel and did not require any stoppage of the study medication as such. So to summarize, lifitegrast group significantly is better than the CMC group alone for all parameters of eye dryness score, ocular discomfort score, OSDI, tear breakup time, Schirmer test score, and the corneal fluorescein staining score. There is improvement in the subject rated global improvement as well as the investigator related global improvement, and I think it is a promising drug and will be available in India very soon. So this is the study or the systemic review and meta-analysis, which also concludes likewise the latest which has been published just a few months ago. So thank you very much for your kind attention.
Thank you, ma'am.
Thank you, ma'am. Any questions from the audience? Okay, so with this, we come to the conclusion of this session. And thank you. Last AIOC annual, when we were doing a IC with Bhupesh, only the speakers were present. This time, at least 30-40 crowd is there, so we are quite happy with that. Thank you, all of you.
And thank you to Dr. Namrata ma'am for including our course in the...
No, thank you.
Please take a
Prafull.
photograph.
I would particularly like to thank Prafull because Prafull has really worked hard with me on the scientific program.
Yes.
And thank you, Prafull, for all your help. I don't know if Anu Malik is there or not. Even she's worked a lot. Thank you.
So they will take...
I barged into Prafull's course.